we've kind of alluded to this when we were talking about Pacific and the EGFR mutant population. One of the things that we've learned is that, immunotherapy is more of a drug for smokers, with all these mutations we have. And we haven't seen a lot of activity of these immune agents in patients with driver mutations. And the data has been emerging. Your thoughts on that data?
So it's sort of been a little bit all over the place. I think the first data that we had was from Justin Gaynor in the EGFR ALK positive patients, showing around a 3% response rate, which was lower than what we had seen from the subset of the Checkmate and the Keynote and Oak trials. And then at ASCO, we had the French data, again, showing lower response rates. And then we've also at World Lung had the immunotarget registry, which is patients' real world data, getting IO, looking at multiple different driver mutations. And that data actually showed that maybe the responses were a little bit higher if you had MET, or although we also know MET occurs in smokers, it's not like EGFR and ALK where it's never smokers. There was, and a little bit higher in, I think it was ROS1 as well. But the EGFR patients were around what we've seen, around 7%. ALK was nothing. So I think that more data is going to continue to emerge, but it's telling us that for patients with driver mutations, the optimal therapy is a targeted therapy, and IO belongs somewhere in second, third line after we've exhausted those options.
Yeah, and it's to me a further on down the line option. You exhaust your TKI possibilities. One of the issues is getting back to what we started with, the combination of chemotherapy and immunotherapy. Do you do that in this patient population when at least EGFR and ALK were excluded from many of the trials? We'll get more data on that, as you pointed out before, about the use in that particular setting. But I thought these two presentations were very helpful in terms of framing the discussion around immunotherapy in these driver populations. Tom, any other thoughts?
No, I think Lior had, you should exhaust the tyrosine kinase inhibitors, and I think if immunotherapy does have a role, it most likely would be in combination with chemotherapy, in these patient populations. I think it's important that the enthusiasm for immunotherapy is so great that we sort of ignored selecting patients who are unlikely to benefit.
Right.
And I think that's really the next step so that patients don't get an ineffective therapy. Right.
But it's complicated because, as you pointed out, in the drivers that tend to maybe occur, like for instance, BRAF. I think when you look at the registrational data, 60% of the patients in there were smokers. And so that might be a subset where there might be more utility. And then, of course, KRAS, which is really, we don't have a good answer for it at this particular time. But,
no. And that one's easier because we don't even have a good drug. And I think the hard part as well is telling patients, because your PD-L1 comes back quickly, you normally get it with your IHC data, you need to wait for your molecular. I don't care that your PD-L1 90%.
Yes.
You're a smoker, you might be ALK or
no, I
positive.
think this is a great point. I made a slide recently. It says genotype trumps everything. The problem is PD-L1 first, but you have to resist that temptation to act on PD-L1. And I say PD-L1 means nothing until you know the genotype of the patient.